A 45-year-old man with a known history of HIV presents with intermittent bright red blood per rectum and severe pain with defecation. I am showing you an actual contrast-enhanced CT of the pelvis. Describe the findings.
All right, let's take a look. The CT demonstrates marked circumferential and highly symmetric wall thickening involving the rectum. The thickened wall exhibits a very homogeneous, solid soft tissue attenuation. This results in significant luminal narrowing, though there is no proximal colonic dilatation to suggest obstruction.
Are there any specific perirectal findings you need to evaluate?
Yes, I would carefully evaluate the mesorectal fat and pelvic sidewalls for any associated bulky, homogeneous lymphadenopathy, which is often present in this setting.
Given the patient's immunocompromised state and the homogeneous, bulky nature of the mass without obstruction, what is your primary differential diagnosis?
The primary differential includes a primary colorectal lymphoma, specifically non-Hodgkin's lymphoma, and a primary rectal adenocarcinoma.
What clinical and radiologic features favor lymphoma over a primary rectal adenocarcinoma in this specific case?
The patient's chronic immunosuppression from HIV strongly predisposes him to lymphoma. Radiologically, lymphomas tend to produce massive, homogeneous wall thickening that rarely obstructs the bowel due to a lack of a desmoplastic fibrotic response, whereas adenocarcinomas typically present as asymmetric, highly constricting, obstructing masses.
If this was an infectious proctitis, what specific CT sign on a contrast-enhanced study would help differentiate it from a tumor?
Infectious or inflammatory proctitis typically demonstrates the target sign, characterized by intense mucosal and muscularis hyperenhancement separated by a hypoattenuating edematous submucosal layer, rather than the solid, homogeneous attenuation seen in tumors.
What specific morphological pattern of gastrointestinal lymphoma presents as diffuse innumerable small polyps throughout the colon?
That diffuse pattern is known as lymphomatous polyposis, which classically corresponds to mantle cell lymphoma.
How would you manage this patient as a radiologist right now?
I would urgently communicate the findings to the patient's referring physician or the infectious disease team, raising high suspicion for an AIDS-defining malignancy.
What subsequent steps would you recommend to definitively diagnose and stage the disease?
I would recommend a rigid or flexible sigmoidoscopy for a deep tissue biopsy to confirm the histologic subtype. Following biopsy confirmation, I would refer the patient for a whole-body FDG PT-CT to complete the oncologic staging.
Assuming this is confirmed as a primary localized rectal lymphoma, what is the typical multidisciplinary management strategy?
I would present the case at the Hematology-Oncology MDT. Management typically involves surgical resection of the bulky localized disease, followed by aggressive, multi-agent systemic chemotherapy directed by the hematologist.